Thank you to everyone for joining us bright and early on the last day. Welcome to the Sunday Potpourri Pediatrics session. We want to remind everyone to complete your surveys after the sessions today to be able to get your CEUs and enjoy this last beautiful day in New Orleans. We're going to start our session out today with Pulsatile versus non-Pulsatile in VAD support with Isaac Chinnappan. Isaac is one of my fellow board members. He is also the chief perfusionist at Johns Hopkins in Baltimore. And we look forward to what Isaac's going to share this morning. Thank you.
So far you didn't hear anything at all? Okay. Thanks for the conference planning committee for giving this opportunity. And thanks so many people came this morning. And also please accept our sincere greetings on behalf of me, Laura, and the perfusion team from Johns Hopkins. If there is a calculation, if there is something to fix scientifically, I can show my way of doing, but pulsatile, non-pulsatile, or continuous pulsatile flows, it's difficult because everyone knows and everyone probably doing the same thing. But from my perspective, I can give few thoughts about this. So the screen is moving here, but it is not moving here. I will try another way. No. Okay, I will use the keypad from here and the screen from here. Okay, so no disclosures. Any problem? It is not moving here, it's frozen.
Okay, we've had a little bit of delay. Okay, you can use that.
I will use this one. Okay. Oh, it is not moving there.
Give it a second, maybe. Okay. Yeah, you're ready. Okay, thank you. Please bear with us as we work through this small AV issue. Oh, there we go. Okay.
It likes your touch.
Okay.
So the objectives of my presentation is we review the science and specifications of these devices and compare the outcomes of continuous flow and pulsatile flow to summarize their implications in clinical practice. Challenges and the level of competency required for the practitioners, especially for the perfusionists, device-related complications, and how to plan for the course of VAD management. So VADs in pediatrics, if you see in the past 15 years, it is either in the revolutionary phase or evolutionary phase. What is the revolutionary phase? Revolutionary means it's going on the innovative phase. Evolutionary means progressive from one level to the other level. Especially neonates and infants and pediatrics in the past two decades, the number of patients has been increased, our way of handling the patients on the ward has been increased. Overall, we are improving, but compared to the adult population, we are far behind. Concepts and controversy. Yesterday during Dr. Wells' talk, I mentioned about this. Patient-specific need, time of decision, or surgeon's preference. These are all still a controversial topic, because if you keep 10 surgeons, if you ask them what is the word for the specific patient, we may get a different information or different intervention. So patient weight and word pump size, still it's a question, because STS says below 3 kilogram patients we should not put on the word, and especially below 2 kilograms, it's not even meant for a word implementation. So pulsatile versus continuous flow pumps, this is the whole comprehensive idea about all the words available in the market now. Mix and match approach, which is widely extended in the pediatric population. This is also I mentioned during my moderating session at the plenary session yesterday, when Dr. Wells mentioned about the continuous flow and the pulsatile flow, because we start with pulsatile, switching to continuous, again coming back to the pulsatile, then right side is like continuous flow, left side is on the pulsatile flow. These are all the combinations we have been working through in the past almost 10 years. So what is the trend looks like? ECMO short-term support in children with heart failure. The ECMO is the ornamental tool still in the past 10 years. The short-term support is significantly improved, and we have been seeing good results. Second and third generation VADs giving hope of new possibilities for children with end-stage heart failure. Continuous flow VADs have accomplished clinical relevance along with the pulsatile flow left ventricular assist devices as the standard of clinical care for both destination therapy and bridge to transplantation. Why I'm mentioning about the continuous flow, I'm not saying the continuous flow is superior than the pulsatile flow. Historically, the aspect of the clinicians, they believe the pulsatile. Yesterday also the other surgeon, when his name is not coming to mind. So the other surgeon came, he mentioned about they want to see some kind of pulsatility. So our mindset was, historically, we know the pulsatile is good, but recently what we are seeing, the outcomes, even the continuous flow pumps are good in the pediatric population. I'll come to this point in the coming slides. So first, methods. Relevant scientific literatures regarding the science and clinical effects of continuous flow and pulsatile flow in peds was performed. Evaluation of the effects of flow and the function of cardiovascular, hematologic, and renal and hepatic were analyzed, and VAD-related complications and the need for alternative VADs were explored. So these authors, first we'll talk about the flow pattern. So these authors came up with an idea or concluded optimization of the future VADs with respect to optimal flow conditions. So the flow is the one which is going to determine which is a short term or long term, and how effectively for the longer support we are going to give to our pediatric population. So the flow is going to make a huge impact on our future interventions. So the other, this article explains about the short-term VADs. So what they conclude, thorough understandings of the available devices, patient-specific indications and contraindications, technical specifics, what is the flow, what type of technical device we are using, and the review of critical factors to be considered for successful outcomes, the inclusion-exclusion criteria, whether if I'm choosing a patient, whether that patient is the perfect patient for the specific type of VAD. So the next one is decision-making, timing, flow pattern. Third one is decision-making. What these authors say is patient-specific need and timing of decision-making for a successful outcome. These are all the one of the area these authors concludes which impact significantly for the better healing process of the patients on the VADs. So when these authors come to comparing the pulsatile, non-pulsatile, or continuous versus pulsatile flow, they're saying encouraging and successful outcomes from continuous flow VADs in peds. This is very important because in the past what we thought, pulsatile flow is better in the pediatric population, but the latest outcomes what they say, the continuous flow also better in the pediatric population, it seems. The reason is When you give the continuous flow in the pediatric population, especially because when I say pediatrics, there is 3 divisions in neonates, infants, then about 2 years to 20 years of age, the pediatrics, especially in the neonates, infants, the vascular compliance, when you give the continuous flow, it creates its own pulsatile, physiological pulsatile, when you're giving the continuous flow. When it is a pulsatile flow, pulsatile device, the pulsatile occurs exterior to the human body. So what is the encouraging results, what it says, even the continuous flow is very useful in the pediatric, in the neonate infant population, and with the continuous flow in VADS and pediatrics. So what is the discussion point here? Berlinot can be used to accommodate all patient sizes from infants to adults with multiple cannula and pump sizes. And it is the only FDA-approved device and pulsatile device with the valves. But what we all know in the past 15 years, the thrombus formation, stroke, bleeding, and infection, from the literature we know, these are all the common problems that everyone is going through it. When you're talking about the CentriMag and PDMag, CentriMag and PDMag optimized for all patient sizes. You know, PDMag we can put for patients up to 15 kilograms, 15 to 17 is a kind of push through, and after that we have the CentriMag pumps for all the way to up to 9 liters or 10 liters. So the continuous flow VADs, patient-specific decision-making keep changing as needed. Multiple VAD intervention or flow-specific VAD support inevitable. That's what I mentioned in the objectives, mix and match, either pulsatile to continuous or continuous to pulsatile, sorry. So how to keep us competent? So because, as I mentioned, we know the surgeon's preference in the adult population, very straightforward, but when we're coming to the pediatrics, it's the mix and match makes us to keep us more competent based on the surgeon's need. Especially if you have 2 or 3 VAD surgeons in your center, we should know their preferences to get ready for whatever the VADs we required. Availability and remnants of the VAD accessories, especially this is a big challenge. Nowadays, you know, we asked for Berlin last week. They said that we don't have any ICAS available in the country as of now. And whenever it is available based on the PO clearance, we'll give the priority for the institutions to set the device. So this is very important because the low volume centers, periodically checking and getting all the information, the accessories and keep it within the hospital plays a huge role. The location of VAD change out also a big challenge because if you have the low volume centers, if you're doing in the operating room, if you're doing in the units, the language of the clinical language, what we are speaking each other, sometimes it becomes challenging. So the continuous flow VADs have demonstrated improved survival and reduced complications compared to the pulsatile flow VADs in the recent years, especially in the neonate infant population. So VADs in pediatrics, again, continuation of the continuous flow, adverse clinical outcomes such as aortic insufficiency, thrombosis, right heart failure, and all those complications we may encounter when the patient is on continuous flow VADs. Recent continuous outcomes encouraging, definition of long-term and short-term, and its clinical significance still it is not clear in the pediatric population. So though the continuous flow VADs demonstrate improved survival and reduced complications compared with pulsatile flow, still we have the surgeon's preference, timing of intervention, and all the unusual complications still keep us in the challenging mode. So the pulsatile flow VADs, physiologic unloading thereby, that is the huge advantage of the pulsatile flow. Physiologic unloading thereby reducing the pulmonary hypertension and the right heart failure. Mix and match approach and eventually ends up with the continuous flow. Because when I'm talking about the continuous flow, finally they are either coming with a PDMag or they are going for the central cannulation and ECMO. So thrombosis at the outlet of the valve is the problem with the Berlin device. Multiple VAD-related issues, complications, and back to the continuous flow support is kind of a common practice in our routine practice. So how to manage when the patient is on this one? There are so many management, routine visits, checking the device. Anticoagulation is a huge challenge, but overall, protocols should approach. Whatever the protocol we have based on the institutional preference, surgeon's preference, we have to follow that one. Anticoagulation is the big challenge, as I mentioned. routine check rounds, subjective matter. That means if I go and check, if I say, I can say I don't find anything, but always what we do at the center, either the nursing staff or the VAD coordinator will be with us so that two people will see and they will come to the conclusion. Only 2 more slides, I'll finish it up. Learn from errors and experience, annual and biannual competencies for the team. And the FPP platform is very useful in the recent years. You know, we can put the question and we can get the information on the same day. Limitations. Although the MCS field has improved significantly over the years, patient versus size versus selection criteria and how to maximize the biocompatibility and hemocompatibility current systems not clear. These complications is very common when we are putting the patient on VAD, whether it is a short-term or long-term or continuous flow or pulsatile flow. Our findings, continuous flow VAD physiology well tolerated over the long term. It is evident that continuous flow how helpful on renal function compared to pulsatile flow since we have the option with increased flow. Flow-specific and patient-specific VAD support and the correct time decision-making could eventually lead to better outcomes. Future studies examining the hemodynamics effects of end organ function and the efficacy of flow-specific VAD support are needed. So in summary, progressive advancements in ECMO and VADs represent complementary modalities of MCS that can both be used effectively in children with cardiac disease. Flow pattern specific VAD, continuous flow, and pulsatile flow support shows clinical relevance based on patient need and the timing of correct decision. A flexible approach to the individual patient is required to optimize mechanical support and better outcomes in this challenging patient population. This word just now I learned from Jim, Potpourri. Potpourri means a mixed up of collected things. In Indian concept, Potpourri means dance with happiness, okay? Here, it's a mixed collection of things. For me, we have the challenges. We may have some kind of low center area, surgeon-specific challenges, all those things. But the potpourri for me, with reference to this presentation, is learn, experience, and educate. That is very important. The third point is whatever I know, I should spread that news to the rest of the people because wherever we are working for our patient population. Educate, competent, and experts. So keep yourself competent, then we all, as a unique team, we can become as the experts. Thank you for your attention.
Thank you, Isaac. That was excellent. Our next speaker is Jim Reagor. Jim is currently employed at Cincinnati Children's as Director of Cardiovascular Perfusion and is an Associate Professor with the University of Cincinnati. He has served on AMSEC's Board of Directors as well as many other committees. Jim is currently an Executive Co-Director of the PD Perform Learning Network, a registry and learning collaborative focused on cardiopulmonary bypass in the congenital population. So this is going to be a PLN update.
If I can get the mouse to work. I got no pointer to, just to even close this and get the next one. I'm just trying to close his, and I got no mouse. It's moving around up there. See, it's working up there, but it's not here. This isn't the same screen. We got no mouse on this. Good call. Thank you. All right, thank you for having me. I appreciate the opportunity to speak today and basically give you what's going to be a 15-minute commercial on the PD Perform Learning Network. So I appreciate your attendance. I want to thank Ron and Molly, pediatric co-chairs, putting this whole setup together. It's been a fantastic meeting, and I look forward to seeing everybody next year. So at the beginning, I just want to take a second and show you the folks that are working on this project. The names that you see here really comprise the PLN leadership, the Scientific Review Committee, the QIC, the Quality Improvement Committee, a list of our project manager and data managers that we couldn't get anything done without. All of these perfusionists on this list had one thing in common other than being perfusionists, and that is that they realize that there's a gap in our everyday practice and the evidence. And I think everybody understands that. We have some evidence-based practice, but the vast majority of what we do is not all that well rooted in the literature. And that's not really our fault. Maybe it is, because we don't do enough research, but we're going to hope to try and fix some of that. With that realization, we developed the Pediatric Learning Network, which is a registry designed to leverage data from a number of different centers while we partner with the Congenital Heart Alliance of Cincinnati, AMSECT, and Cardiac Networks United. Cardiac Networks United is a group of pediatric-oriented learning networks such as PC4, which is a registry and learning network for the pediatric ICUs, cardiac ICUs, PAC3, which is the step-down units or the floor, ACTION, which is mechanical circulatory support, as well as MPC-QIC, which focuses specifically on patients with hypoplastic left heart syndrome. All of those organizations, CNOC, which is a neurocognitive outcomes group, all those organizations, including PLN, underneath CNU, will be able to collaborate and share data with each other and look at outcomes over long periods of time, especially, and I'm excited mostly about this one with CNOC, the neurocognitive group, because we might be able to start tying some stuff in to long-term outcomes. Our mission ultimately is really, just like anything else, to improve the congenital cardiac surgical outcomes and value to the patient, the families, but also to the teams that are performing this work every day. We have 7 charter institutions that include Nationwide, CHOP, Norton's in Louisville, UT Southwestern, CHOA, Medical City in Dallas, and then Children's Mercy in Kansas City. All of which have committed to participating, and including the 3 founding institutions, Michigan, Colorado, and Cincinnati Children's. That gives us 10 centers at the outset. Of these 10, 8 have completed the onboarding process and are contributing data to the system. And for the rest of those groups that you see there listed, they're all somewhere within the, hey, I'm going to do it, and we're getting ready to do the contracts, all the way through onboarding, but not quite yet to participating. I just had the pleasure adding Primary Children's to that list yesterday. There's about 120 institutions, so that's 14 centers. There's about 120 institutions that do pediatric perfusion throughout the nation. 40,000 kids, as you guys know, get born every year with congenital heart disease. We're not interested in all of those, of course, because we're really focusing on just the ones that do that get cardiopulmonary bypass. But what's kind of exciting about this is just with this list of folks that you see here and those relatively conservative numbers of annual bypass cases, we're already covering 15% of the cases that are done in the United States. And that may not sound like a huge number, but I think it's actually a pretty good start. At this point, as of yesterday, we had 3,816 records in the database in just a couple of years' time. So now let's take a look at what kind of data these centers are collecting. There's about 150 fields that are collected, most of which, don't be scared by it, most of which of those are standard pieces of information that should be in any complete pump record. We start out with the personnel. Now what's important to understand is when you see perfusionist and surgeon, and then after our update this year, you'll also be collecting anesthesiologist. The entire registry, and I'll show you an example here in just a moment, cannot break your cases down within your institution, and they can't see your case level They can't see your surgeon or your perfusionist or your anesthesiologist or anything like that, but you can at your own institution with the perfusion comparison reports and the institutional reports. There's a third report, and we'll go over it in just a second, that's the blinded site report. And that's the aggregate data from each institution compared with whatever measure that you're going to be looking at. So only the folks within your institution can break it down granularly, and we'll talk why that'll be important in just a few minutes. There's a few other things that we look at here. We've got the equipment, which is your cannulas and your tubing sizes, your heart-lung machines, tubing coating, all that stuff. Temperatures, what you cooled to, what you came off at, what your highest arterial inflow temperature was, cardioplegia solutions, blood gas management, did you use alpha stat, pH stat, what temperatures did you start those or stop those, and then lab values, letting us look at AKI or anticoagulation and that sort of thing. We also look at volumes for fluid management, as well as information around techniques in the conduct of perfusion like ANH or RAP or VAP, and those kinds of things, whether or not you use vacuum. There's also 5 postoperative fields that we collect, which include creatinine, first creatinine in the ICU, peak 48-hour creatinine, peak lactate in the first 24 hours, and then 24-hour chest tube output. So we're looking at those as well. Those are the ones that take a little bit to dig in and get after the case. The rest of it should already be included in a pump record. Now, that's the data we collect, so let's get into a little bit of what we can do with that data and what PLN can provide for your institution. Each center has access to the database, as you see on the screen here. These are the current reports that we have available and a variety of benchmarking opportunities. To begin with, we've got kind of just the basics with the case mix report, that's demographics, how many cases were done, that sort of thing, equipment usage, data quality reports, which allow you to look at those records and make sure that all of your the records that you think should be in the system are in there. So that's just kind of a way to make sure that we're tracking all the records that we should be tracking. We've also got below that, there's blood utilization reports and prime reports. And then on the right side there, you see conduct of perfusion, conduct of bypass times, as well as fluid management and lab reports. And each one of these reports comes with a blinded registry view, an institutional view, and then a perfusion comparison view, which allows, as I mentioned earlier, the institution to break down their cases by perfusionist or surgeon, or as mentioned in the future, by anesthesiologist, or any combination of those. So as the registry is still young, I don't really have any amazing data to share with you. You know, Perform does a lot of great stuff with the data they've been collecting over the last almost 15 years. We're moving towards that, and that's kind of our purpose, is to be able to provide those kinds of QI projects for our profession. But right now, we're still collecting the data. We've kind of set an arbitrary time frame of 3 years of data collection before we start digging into it, so we really have a good mix of data and a decent amount of data. And like I said, I kind of project us to have well over 6,000 records in that time frame based on new teams coming on board and the number of cases that we've collected so far. But over the next few minutes, I just kind of want to show you some examples of what you can do with it today. Before we take a look, though, I want to quickly explain kind of what you're looking at and kind of define the layout of each of the dashboards. Each institution is represented here. This is a case mix report for neonates, so it's just the number of neonates that each institution is in the database. And my institution, or if you're looking at it under your login for your participating institution, is represented by the star on the blue bar there. So that's Cincinnati Children's data that you're seeing there. The filters on the right allow us to get really granular in our data displays. We can break down by date range, age, size, stat category, any of the benchmarking, the STS benchmarking procedures, was circ-arrest used or not, and then a bypass time frame window, as well as the number of hours that it takes for the bypass runs. And finally, the black bar there that you'll see is the registry mean for the entire measure that you're looking at, which doesn't mean a whole lot in this picture just because it's a case count. So I can take a look at this graph and I can see where we land, Cincinnati Children's, compared to everybody else in the rest of the network. But if somebody's doing better than us in a measure, how do I learn from them, or how do I know who to get in touch with? And one of the conditions of participation within the network is center-level transparency. And what this means is I can't, like I mentioned earlier, I can't break down your cases by surgeon, perfusionist. I can't go any further into your data than the registry, than the institutional level, the aggregate data of the institution. But what I can do is I can hover over any of these bars, and you'll see a blinded site number. There's a site, I think that says 780 there. That's a blinded number that changes every year. And only the clinical champions for each institution have access to that key that is held on our SharePoint site. So if I see something and I want to be able to reach out to an individual and ask them how they're doing something, I can look up that site key, I can find out who the clinical champion is for that site, and I can reach out and contact them and have that conversation. So this allows us really to benefit from the ability to learn from each other, but still have a level of data security that prevents unauthorized use of the data. Now, why would we want to do that? How does that help us? Real quickly, if we take a quick look at this equipment report, for example, on what arterial line diameter is being used for kids up to 6 kilos. Cincinnati Children's, we use 3/16 arterial line for that, but there's some institutions here that use 1/8" arterial line for some of those patients. So I could reach out to those guys and I could say, what flows do you use for that? How do you make the connection to the cannula? What line pressures do you tolerate? Any question that I might have for them, so that if I go to implement that at my institution, I can feel better about it because I've talked to somebody that knows, that has done it and used it, and I can do it within about 30 seconds, just pulling this graph up, taking a look and looking up who they are and making a phone call. Another example of a little bit deeper dive here is, because that's just one graph, but if I want to combine a bunch of different opportunities and a bunch of different measures, here's an example of blood use. So this is a chart that shows blood use in the prime and on bypass. We look at blood product utilization in the prime, on bypass, or throughout the entire perioperative time course, so you can combine all of those. This is just bypass and in the prime, so what we did to the patient, and we're looking at it just blood and in usage in mLs per kilo. And then this is for about a little over 600 neonates. And what you can see here is the 3 centers on the left. We're going to focus on those guys. They use the lowest amount of blood based on this report. But why is that? So this is a chart of who muffs within the registry. So 2 of those centers muff, but 1 of them does not for the vast majority of their cases. So I can pull that up and see, okay, what else is it? Is it their prime volume? Prime volume in mLs per kilos for neonates. Well, 2 of those centers are lower than everybody else. So maybe that's got something to do with it. What else might impact it? RAP and VAP. So this is a question of who RAPs and who RAPs or VAPs on their cases. You can see that second from the left center, they RAP and VAP 40% of their cases, which is quite a bit more often than everybody else does within the registry. What about A and H? Well, that second center from the left, they do A and H on about 14% of their cases. So things are kind of starting to stack up with those 3 on the left that were kind of a little bit lower blood usage. So what is it that I can look at it and see what is it that these places are doing that are maybe impacting their blood utilization? What about hematocrit targets? This is a chart of average post-protamine hematocrit. And as you can see, that second to the left center, they have a little bit lower hematocrit target post-bypass. It's around 30, a little bit over 30, where the rest of us are in that 35 to 40 range. Now again, these are all-comer neonates, so cyanotic, non-cyanotic, and all that, but you can still kind of see a little bit of a trend there. So if we go back to our first chart of blood usage, in the prime and on bypass, the center with the lowest blood use is also a center that does not muff, but it does have the lowest prime volumes, utilizes RAP and VAP, and A&H, tolerates a lower hematocrit as well. So while this is really just descriptive data, it certainly allows me in a very short time to take a look at blood usage, drill down to some of the techniques that might be used to help with that, and give those centers a call and find out what, more specifically about their techniques and what they're doing to help me maybe reduce my blood utilization. And I'm out of time, so I'm just going to go through these last slides very, very quickly. There's other measures that we can use. This is an example of our CPB fluid balance within our institution. I'm showing this to show these names are everybody on our team right now. I can take a look at this. We practice very, very similarly with our institution, so there's not a lot of variation here. But if you want to look at your center and work on minimizing variation within your center, you can collect data for a while, pull up one of these graphs and see where the outliers are and who might be doing a better job than someone else within your team. Talk with them and find out what they're doing and bring everybody on board with the same processes. This is again, I'm going to just skip this because I'm out of time, but so what's the future hold? Right now, we're collecting the data, we're updating the database. We're going to do that first database update this year. We're going to work on more reports. Big pie in the sky idea is continuous data collection. So we want to be able to start bringing in data by the minute, maps, flows, temperatures, the whole kit and caboodle, really do something with that. And then we'll be having some PLN meetings. The purpose of this is not just for a bunch of people on the executive committee to decide what reports you guys get to see, but for the community to decide what they want to see. So in those meetings, we're going to be able to get ideas from the participating centers and build upon those reports that you saw there, even the different measures within those reports. And then of course, out of that will come QI projects. So I appreciate your time today. I'm going to shut it down there, but I want to just say thank you and let you know that you can come chat with me or go to the website if you have any questions. Thanks.
Thanks, Jim. Very exciting stuff. If you're not already a member, definitely consider joining. I'd like to introduce our next presenter, Dafne Chianella, pediatric perfusionist at MUSC and our fearless leader on the AMSEC Pediatric and Congenital Perfusion Committee chair. Daphne's going to talk about a priming toolkit.
Look at me getting it working the first time in 5 days. So thank you so much, moderators, Tammy and Rachel, and thank you so much for everyone for being here on Sunday. I'm really excited to talk to you about this today, the Pediatric and Congenital Perfusion Committee's protocol project. So a little bit of objectives. I'm going to give you a little background on the PCPC, our priming toolkit, updates on the standards and guidelines, and future projects. So I always like to start with our vision and mission statement for the PCPC. I think it's critical. The vision for AMSEC's PCPC is to improve safety and quality of care of patients with congenital heart disease. And the mission is to define a body of knowledge consistent with evidence-based practices, facilitate opportunities for collaboration among providers, and to improve quality of care as it relates to perfusion and the subspecialty. So key points in there is evidence-based and collaboration, I think. And here is our wonderful team. I couldn't do anything without all of these very special people. So many of them you'll see in this room. I think we are going to expand a little bit. So please follow the FPP emails for updates on that. So the protocol project has been ongoing for several years. It started on the adult side, and in 2021, we adapted it on the ped side. We published the pulmonary artery flow study with four unifocalizations and the TPE protocol in 2022. In 2023, we published the MUF protocol, which should be on the website. Still waiting for that. And in 2024, we are aiming to publish our priming toolkit. So, and this you'll find directly on the AMSEC website, under clinical resources, and the newly added pediatric perfusion tab, which if you haven't explored that yet, it's beautiful. So the following documents are created by AMSEC and are essential to differentiate and have specific backgrounds with intentions of use. While the design of each one is to help standardize and improve the conduct of CPP, they differ by level of evidence and approval. And I think that level of evidence I'll bring up a little bit later. The clinical protocols, the ones we've generated, the three, are from various institutions, published literature, and committee consensus. They have less rigorous requirements than something like the standards and guidelines, but they serve as a template for institution protocols. So how does the toolkit differ from the protocol? And we actually wrote 2 protocols, one for priming and one for circuitry, and we struggled within the committee on how to do that. As you know, and as you've seen over this weekend in this room, the amount of variability. We're all doing things relatively similar, but just different enough to make it difficult to make it a protocol. So we decided to work towards a toolkit. So it's not a difference by protocol, but it's not a step-by-step, and it's not necessarily instructional. This is a should-do document. The toolkit resources and template models are already on the AMSEC website under the clinical resources, and it's generalized information that's broadly applicable and inclusive for all of our institutions. So other examples of toolkit items are the DO2 chart, patient care, and we saw those actually in the oldies but goodies. We brought some of these up. So the DO2 calculation chart, the patient care plan, and you can see some of these are Excel sheets, or you can plug in numbers and use them in your institution. And then the supply chain, which is just a list. So we started with, like we do with everything else, we turned to the FPPs. We asked all of you, can you share, were you willing to share your protocols, your working tools, your own toolkits? This is the best resource we have, and probably one of the most amazing aspects of the FPP is having so many of you at our fingertips, and it's so incredibly responsive. We instantly got tons of responses. This is a snippet of it. We have actually more coming kind of monthly. Someone digs up an email and we get more participation. So thank you to all of these hospitals and everyone who's contributed. So this was the priming constituent toolkit for pediatric and congenital cardiopulmonary bypass. This is the beginning of the protocol, and we wanted to include this in the toolkit as well. So it's to provide a guideline and resource for priming the cardiopulmonary bypass circuit for patients with congenital heart defects from neonates to adult. The toolkit will provide basic requirements for prime composition, taking into account physiological needs of varying patient age and size. It provides equations for BSA, flow, gas exchange, blood composition, drug administration, equipment selection, anticoagulation, and other congenital perfusion techniques. Our goals were to maintain a physiologic electrolyte and acid-base balance prime while minimizing hemodilution. The use of pre-bypass ultrafiltration may be used to attain this goal. Ensure prime composition meets the patient's metabolic and cardiac output needs once on bypass based on patient's age, size, procedure, institution, and surgeon requirements. Blood products, included but not limited to packed red blood cells and FFP, may be added to maintain acceptable post-dilutional hematocrit per institution and surgeon preference. And our target population is neonates through adults with congenital heart disease. I want to give an extra special thanks to these institutions who actually sent their toolkits that were with all equations available. So I forget what that's called. I don't know, open on Excel. You can tell them Excel. I'm an Excel genius here. So extra special thanks to you guys. And some of these things may seem a little familiar. So my goal was to get into the document and actually play with it. We're having enough difficulties, and like I said, technological genius here. I'm just gonna go through with some screenshots. So with the first page, I wanted to show on the bottom, I can zoom, here we go. We have several pages in our toolkit. It's pretty extensive. Some of these may even be taken out and used later on for a separate toolkit. This is gonna be an evolving project. But we wanted to start by defining all equations. So this took some time. From all the equations we received, took each one from each institution and went back to the literature and collected all of those. So I wanted to just focus on, those are the purpose and goals from the other page. I wanted to focus just on BSA, just BSA alone, something we use every day. We found 4 to 5 variations within each institution. So for a BSA for less than 30 kgs, a BSA for a greater than 30 kgs, one using just the divided by 36, one using a BSA if you don't have a height. So you can already start to see that we're all using BSA, but it's slightly different. This makes this project a little challenging, and why a toolkit may be better than a protocol. This is just a continuation of that list of all the different equations, and it's pretty lengthy. It goes on and on to the bottom of the page. So this is an example of what we're hoping it'll end up being as a toolkit. These are the same things on each page. This is the calculation page on the bottom. I just took a screenshot, and so this continues over to here. But the idea is, with this, just like the toolkits many of you are already using, just by putting in some information in the yellow squares, you're going to have your patient, your age, your date. You'll be able to put in height and weight, and you'll have everything from hematocrit, platelets, fibrinogen, COP, AT3, and even in this conference, sees other people collect different things for their prime than others. So we were adding those as the conference went along. You'll be able to generate anything you need. You'll have your blood volume, plasma volume, total blood volume, total plasma volume, and that can translate into your flows. So the idea is you'll have all these numbers in one page. I also extended this for, I think I initially had it stopping at 3.0, and then after hearing a couple of these talks, extended it to 4.0. It's been a wonderful, wonderful week. And then I also added, we also added the drugs. Just the prime drugs, what each institution puts in, varied greatly. We all have heparin, we all have some kind of fluid, but everything from Lasix, Regitine, thrombate, lidocaine, there was a variety of different drugs added across all these institutions. So rather than putting it all in one place, the idea will be you will have these in the definition page or the calculations, and you can move these over into your own toolkit and customize it. You'll have all these definitions with some kind of resource attached to it, and you can build your own toolkit per your own surgeon and institutional needs. The idea is you'll have everything in one place, and you can customize it as needed. And then even, this is for Del Nido. Some places don't use Del Nido, but the example will be down here. It will eventually, you can put in your cardioplegia information as well. There was a lot of talk about osmolality, and I think a whole separate page for that is important as well. Isaac, this is for you. This is critical. This is just one example. There were, oh, what makes you happy? Oh no, what happened? There you go. So this is just one example. This also gets kind of in the weeds here. Several calculations for this. Many of them are in the definitions page, but I think this is an exceptional part of the toolkit because I think it's underutilized. And I did not see this on as many protocols as Isaac would like. Anticoagulation. These, I was surprised, were pretty much similar. 2 examples of some of the calculations you'll be able to plug and chug. And exchange transfusion. I thought this was an amazing tool. Here are 2 examples. One's pretty simplified. You just put in your volume, how many times exchange, and your units of blood and FFP, to this one that breaks it down into ABOI, sickle cell, and I think like what an amazing tool to use and to have at your fingertips. Like I said, we also had started a protocol for circuit selection, and you can imagine how challenging this one was. We got kind of far, and then we started to see 1, 2, 3, 4, 5, like they just kept coming, right? Like all the different versions of your circuits that are out there. But you'll see they're all basically the same. They're similar but different. There's this AB, Pixie, there's this 3/16 a quarter. We're all doing something similar. This infant, neonate to large adult. Kevin's an outlier. The Kevin circuit is different here. And then there's also this Chodler, which I really liked. But the numbers are more similar than you would think. I'm pleasantly surprised to see, and all of this information, Jim, you probably already know this with all your registries, that while we're different, we're doing things more similar than we thought. The last page was for deep hypothermic cardiac arrest. either meds, this was given through anesthesia or through the perfusionist. And this would be another page I think would be really helpful that we're planning on adding to the toolkit. So this is the beginning steps of this. We have a long way to go to make it beautiful and perfect to present, but the point of this talk is to show you where we're going and where we started. Right now I'm presenting it to you guys in the pediatric community. Then we're gonna, after it is finished, we'll bring it to the ICEBP, then legal review, and hopefully send it to the board of directors for approval, the goals by the end of the year. So we have some work to do. I included this, and I want to go really fast. This was a publication in the Journal of Cardiac and Vascular Anesthesia in 2019, and they say some words that kind of hurt. Evidence-based strategies to reduce blood product exposure are evolving, but there are no specific practice guidelines for pediatric cardiac surgery perfusion that have become widely accepted. This was published in 2019. The standards and guidelines were published that same year. Most protocols for pediatric perfusion are based on institutional policy and experience and training of the surgeon, anesthesiologist, and perfusionist, and this hodgepodge of practices has made it difficult to establish clear, universal, accepted pediatric CPB guidelines. That was supposed to line up. I do not like that word hodgepodge there. I think it's clear that within our institution and in others, there is nothing that's universal, and not that we can make it necessarily universal. Their conclusion states that given the lack of standardized pediatric perfusion protocols, studies in the pediatric perfusion are clearly needed before effective evidence-based practices for pediatric CPB can be developed. We need to keep standardizing protocols, developing protocols, publishing our research, publishing data to move this forward. We can't have hodgepodge protocols out there. So that's one of our goals, right, as the PCPC. And I'm going to transition quickly to the standards and guidelines and give a quick update on that. A small group of us have been working very, very hard. So Molly, Ron, Chelsea, Ashley, Isaac, Tom, there's a lot of work that has gone into this over years. If you haven't already scanned your QR code, please do so. I'm running out of time, I'll go fast. We need your feedback. The standards and guidelines have 21 standards to them. It has been lots and lots of works draft just for the 2019. Now we have to update that. It's 2024. And we had the two publications, like I said, they came out, this one actually came out in 2021. So anesthesia did not read it. But this came out in for 2019. We have, Molly had sent out a survey. Has your institution and practice incorporated the standards and guidelines, the 2019s, into your practice guidelines as a result of the publication? And it was wonderful to see that 54.8% actually had changed, incorporated the standards and guidelines, and 42.9% had utilized some of them. Did you find it helpful to have an approved document such as this to refer to as a justification for making and implementing due to costs and or other restrictions? And 85.7% said yes. So the standards and guidelines are helping institutions get what they need when they need it, and they have this document to support. Some of the updates we are trying to do for 2024 is a more focus on DO2, flow rates and hemoglobin contributions to DO2, in addition to gas exchange, and to the incorporation of osmolality to prime considerations. Another is washing all PRBC products for prime and or CPB. There are a lot of new references that takes, even though it's only a few years difference, that takes a lot of time, and it's critical to update them. Continuously versus continually, that is a difference. Continuously means without a break versus continually, which is done periodically. So we may be continuously monitoring our blood pressure. We never stop monitoring that, but we may continually ultrafiltrate, stop and go. So those words were updated. And then there were a lot of additions to from the adults that we have also pullen over. There's a guideline up to a standard for data collection and registry participation. There you go, Jim. And consolidation and rewarding of various other things. So we really need your feedback. I encourage you to scan this. Between the toolkit and this, we need input and as much of your support as possible, and it's only possible because of this amazing community. So thank you very much, everybody.
Thank you very much, Dafne. Next, we have Bradley Kulat. Bradley has been a pediatric perfusionist at Lurie Children's Hospital of Chicago for 32 years. He is a very active member of the perfusion community professionally, serving as past president of the American Board of Cardiovascular Perfusion, among many other things. In his free time, what little there is, Bradley is a competitive master swimmer and rugby coach. And he is going to be talking to us about AKI and pediatrics.
Thank you for the introduction. As I get this slide up, I just want to thank AMSEC for inviting me and the pediatric committee for putting on such a great meeting. And to reflect on what Bob Groom said yesterday, I've seen AMSEC as lowest. I've also seen it rise. So congratulations to leadership here and keep on going, man. Love it. So we're doing some good stuff here. I'm having a difficult problem. How do we get out of this? Molly? I'm clicking on it and nothing's happening. How'd you do that?
Just got lucky.
Great, thank you. So my talk's about AKI and pediatrics, and what got me interested in AKI and pediatrics was our ICU. Our ICU is basically blaming us, the perfusionist, for all the AKI in the hospital. It's unfair. But I also want to stress that we've been learning a lot about DO2. However, my take-home message is it's not just all about DO2. Don't get me wrong. DO2 is a very important measurement and a great tool for us, but it's much more complicated and involved than that. So my objectives are to review renal physiology, to define AKI and its causes in pediatric cardiac surgery, and to discuss perfusion strategies to prevent AKI and improve patient outcomes. So just a little refresher course about the kidneys. We're all going back to school for a little bit here. The kidneys obviously have a large blood supply. Goes to your kidneys. The kidneys can be basically defined as the cortex and medulla. Cortex, the outer part, medulla, the inner part. And 100% of the renal blood flow goes to the renal cortex. However, only 10% of that blood flow goes to the renal medulla. So the renal medulla contains the loops of Henle and invasa recta, and the process of sodium transport by the thick ascending limb of the loop of Henle accounts for the high oxygen consumption. So the cortex, the renal cortex has a PO2 about 50. The renal medulla has a PO2 around 10. And therefore, the renal medulla receives less blood and a lower PO2. So the renal medulla is really living on the edge here, and we could really tip this over very quickly. So autoregulation, just like the brain, the kidneys are able to autoregulate to maintain a constant perfusion pressure by altering the renal vascular resistance depending on the blood volume and the blood pressure. So for example, if the cardiac output decreases, the afferent arteriole dilates and reducing renal vascular resistance. We will come back to autoregulation a few times in this talk. So what is AKI? Well, the general definition is a sudden or rapid decrease in renal filtration function within 7 days. And AKI is a result of injured renal tubular cells located in the renal medulla, as we just talked about. And it is a common postoperative occurrence. Literature is all over the place on this. It's 20% to 50% to 60%. So it's sustainable and substantial, I mean. Over 5% of these patients will go on to require renal replacement therapy also. It does increase mortality and morbidity of our patients also. The standard classification for AKI is KDIGO, and I'm not going to go too much into this because we only have 15 minutes for this large subject matter. But there's 3 different stages of AKI according to KDIGO. But the take-home message on this is it's within the last 7 days. So an increase of your creatinine 1.5 times in the last 7 days. So a week later, we still have to be thinking about AKI post-bypass. There are many risk factors of AKI in pediatric cardiac surgery. As you can see, the list is extensive, and there's probably more we can put on this list. There are also independent or standalone risk factors of AKI in pediatrics. Age less than 12 months of age, use of bypass, use of cross clamp, cardiopulmonary bypass duration more than 90 minutes, bank blood usage, a high RAC score, pre-existing renal dysfunction, and your nadir or lowest DO2 on bypass. So what can we influence as perfusionists? Everyone in this room has the power to influence and modify AKI and their practices. So as you can tell from this list, we can't control the age. We can't control pre-existing renal function. Well, we have to use bypass to repair their pathology. Prolonged bypass times and cross clamp. Well, let's get better surgeons or quicker surgeons. That's not going to work. So we can control the nadir DO2. So as we learned, why is measuring DO2 important? Well, because of the kidney physiology, high blood flow, high oxygen consumption. And from our equation here on the left, which we all have seen a million times, I used to calculate this on bypass like every 15 minutes before monitoring came out to make it more efficient. But DO2 is a product of cardiac output and the oxygen content of your arterial blood. 2 main driving forces are your cardiac output and hemoglobin, very important. Many of us have goal-directed DO2 management strategies and protocols too. It's used to maintain our nadir DO2 above the nadir level or the lowest level. So what is the optimal DO2 for us? Well, it's a good question. It seems like the literature is still undecided, and hopefully Jim's study will bring this about in about 3 years, and we can get a better definition of this too. But in theory, DO2 thresholds should be higher than in adults because of the high metabolic rates of children. Literature out there says Zhang is DO2 about 353, Bojan is about 340, Hayward is about 350. There's also articles out there that state there should be different goals for hypothermia and rewarming. So Gao has this article on DO2 of 258 during hypothermia and 281 during rewarming. I don't know about you guys, but that makes me a little bit nervous. So we'll take that into account. There's also other studies too that say a better predictor of AKI is the largest area under the curve. Below the DO2 threshold. So cumulative time and depth underneath the curve might be the most important factor. And this makes sense to me. The deeper and longer you go, that's probably what's causing the damage here, not just slipping below your threshold once in a while by a couple points. So another modifiable risk that everyone in this room can address is hemodilution and blood transfusions too. So we all know that the main reason for hemodilution and our need for administering blood products during bypass is the disproportional ratio between our priming volume and the patient's native blood volume. And this can be also true for smaller adults too, if there's any adult people out in the crowd. So cardiopulmonary bypass-related hemodilution is one of the main contributors to renal damage. As we just talked about with DO2, hemoglobin is a big factor here. You decrease your hemoglobin, your DO2 is going to drop. And also decreased viscosity too in your kidneys. This causes renal tissue perfusion defects, vasoconstriction, and tissue hypoxia. The renal autoregulatory systems are greatly affected by this also. So as we talked about earlier, the autoregulatory system, if we wash out the vasoactive substances, this can really affect renal microcirculation and alter the renal blood flow. I don't know why we're having some background. Yeah, so sorry about that. Bank blood. So great. So to avoid hemodilution, okay, let's give blood. Well, we all know blood is a life-saving substance. However, it comes with a lot of baggage too. And bank blood undergoes irreversible morphological changes during storage. It's not fully understood, but bank blood is also thought to affect the kidneys and activate AKI in some patients by causing immune response and inflammation and oxidative stress. And storage lesions of red blood cells cause it to become more friable and cause more hemolysis in your pumps. So how do we reduce our hemodilution and dependence on bank blood? Well, the SDS et al. Came up with some great articles throughout the years on how to really manage hemodilution and blood conservation. And one class 1 level A recommendation from this consortium was miniaturizing your circuits. And that's one thing that everybody in this room is probably going towards or is really making strides to do. We took action on this many years ago. Probably since like 2005, we threw all of our pumps off of our circuit, and we actually published, Neil and I published an article in JECT in 2009 on how we did this. So this is another couple views of our current pump. And as you can see, everything's nice, close together, centralized, close to the patient, really reducing our prime volumes. And here are two more modern examples. On the left, you have the Essence systems. We had it in for a trial, and we really were able to modify the Essence systems pretty closely to what we currently have. I was actually pretty impressed by this. I thought, seeing the Essence systems, like, there's no way this is gonna work, but it actually kind of did. And on the left, I snuck into Jim's closet and took a picture of his system during the pediatric retreat. So as you can tell, most of us are going more towards a remote mounted circuit, reducing our prime volumes, reducing our dependence on bank blood. So prescriptive perfusion was a hot topic, kind of buzzword for many years too. And basically it is matching your tubing and your components to the patient's size. So it's no longer one size fits all, or you get one or two choices, that's it. You really want to just prescriptively match everything to your patients. Ultrafiltration size even matters too. People always complain about the smallest junior and stuff. Well, it's only 8 ml prime, doesn't work that well. Well, of course it doesn't work well. It's small. You just have to expect that and just stay ahead of it. Tubing sizes, match tubing size to your patient. No acceptable flow rates too. A lot of people, and it's one thing I ask my students all the time is, what is the acceptable flow rate for this size tubing? Oxygenators, we have 4 different size oxygenators, 5 different size tubing packs, and 2 sizes of ultrafiltration units. So we really try to prescriptively match our patient sizes to our equipment that we're using. We also all have the power to limit systemic inflammatory response too. So from the consortium too, there is a near universal agreement that minimum circuits limit markers of inflammation compared with conventional bypass circuits. So just think about it. The non-endothelialized foreign surface of your tubing and components activate to complement and innate immune systems, which can lead to AKI. Again, this makes sense to me, that the greater the foreign surface area, the more reaction that's going to take place. Smaller, not so much, but we all have the power to cut everything down and make it smaller. Next is low cardiac output, hypotension, and high CVP during bypass. So low cardiac output, well, we all maintain our indexes and maintain a high cardiac output. And also it's a direct influencer of DO2, as we talked about earlier. High CVP, drainage, your IVC cannula is very important. You back up your venous flow to your kidneys for a long period of time, it's gonna give the kidneys a knock. So correct any drainage problems immediately. And we use venous flow probes, probably a lot of people do too. It really helps you diagnose your venous drainage and win arguments in the operating room too with a crabby surgeon. So hypotension. So here's where renal autoregulation is coming back to us again. You can have adequate cardiac output, but a low MAP, and this can really affect renal autoregulation. So I think it's important to consider mean arterial pressure as part of your AKI intervention strategy. Bojan, going back to Bojan again, she said that when renal autoregulation is compromised, renal injury occurs as a result of relative hypoperfusion and hypoxia, and it leads to tubular injury. She also said that maintaining the perfusion pressure above 60% of normal age standardization and mean arterial pressure may provide an effective renal protective strategy. One last article too is Kanji said that change in mean arterial pressure greater than 26 millimeters between pre-bypass and during bypass is associated with AKI. So I think the lesson here is to keep your MAP within age-related ranges. That's up for debate. I mean, all of us probably have different ranges here. So that's kind of a gray area that hopefully we will know more about in the future. I think besides flow, blood viscosity is very important here too. We teach our students sometimes that, okay, you're getting a little soft on pressure. Crit is okay, it's above your protocol threshold. But if you ultrafiltrate and make that blood viscosity a little higher, you'll see your mean arterial pressure shoot up. And that's a Starling law too. Viscosity is a Starling law. So that's going to affect your blood pressure. And also kneel, but I consider kneel as almost a last resort. So flow, get that crit up, get the viscosity up, kneel as a last resort. But more to come about that, and hopefully we'll know more about MAP ranges. So lastly, we all have the power to limit plasma-free hemoglobin. There is really evidence that hemolysis can really impact the kidneys. And we all know that significant hemolysis occurs during bypass, and it is associated with AKI. We kind of judge it by wines. Okay, what are you right now? Well, we're at a rosé, and then you go all the way up to port. And we do see sometimes where we just have garbage coming out of the catheter, and we've done a lot of damage here. So we need to really take this in consideration because free heme causes endothelial damage of the kidneys and oxidative damage to the tubular cells. How do we do this? Pump sucker management is very important too. Speed to need. Surgeons always say, crank it up, crank it up, crank it up, okay? We're gonna crank it up temporarily, then we're gonna turn it right back down. Reduce sucker tubing length too. You have 8 feet of tubing sucker, and it's this co-aspirated air and this froth coming back to you. You are just chewing up those cells, and you're gonna get plasma-free hemoglobin. Controlling your RPMs, I said, match speed to need. Cannula and circuit sizes too. Know your appropriate cannulas and your circuit size. A high pressure drop will cause hemolysis over a period of time. Anticipate your patient's needs too. So collaterals, and plus what are you doing in the surgery too? You might have to bump up your cannulas and prove that argument to the surgeon that I need a bigger cannula because of collaterals in this patient. So again, circuit length too, resistance is to length too. The higher length of your arterial tubing, the greater resistance and the greater pressure drop. Occlusion settings and pumps, of course, are very important, and we already talked about bank blood and the cell fragility of it. So in conclusion, the pathophysiology of AKI in congenital heart surgery is complex and can have multifactorial causes. And perfusion-related causes of AKI, such as a low nadir TO2, hemodilution, systemic inflammatory response, bank blood usage, a low MAP, and generation of plasma for hemoglobin are all under our control. So bypass-related AKI may be better mitigated by using a comprehensive AKI preventative perfusion strategy and not just focusing on one factor. Thank you very much.
Thanks, Brad. I'd like to introduce our last presentation for the session. Samantha Reimer, pediatric perfusionist at Lucille Packard Children's Hospital, will be talking to us about the Berlin active driver experience.
And then you just do slideshow. Okay, thank you, Tammy and Rachel. So like she said, my name is Samantha Reimer. I work at Stanford Children's, and I'm going to talk to you guys about the new driver from Berlin Heart called the X-Core Active. I'll go through kind of the new features of it and what we found that we like and dislike about it. For disclosures, I do want to mention that we were part of the trial to test out the active driver at Stanford Children's, but I have no other disclosures. And first, the trial was a coordination between Berlin Heart and the Action Organization. So they enrolled 40 patients. There were 15 children's hospitals that were involved, and it only took 10 months for them to enroll these 40 patients. To date, I believe Stanford Children's has done 15 initiations with the active driver. And before I get into the new features of the driver, I'll do a quick review of the ICUS that hopefully most of us know and love or hate. It is the stationary driving unit that is very heavy, weighing approximately 100 kilos. There is the integrated laptop that we use to change and review our settings. There is a very short battery life of 30 minutes. And the ICUS uses compressor technology for our suction and driving pressures. And there are 3 systems in the ICUS. So what that means really, if you have a BiVAD, one compressor system runs the LVAD, one compressor system runs the RVAD, and then you have a third system that acts as your backup. And so next we'll go into the new active driver. It is much smaller and a mobile driving unit, only weighing 15 kilos, a much longer battery runtime with a minimum of 5 to 6 hours. We are also able to now measure flow with the driver. And instead of the integrated laptop, you have a touchscreen panel PC. And then I don't know if you can see on the top of the driver, there's a panel there that you can scroll through and see your settings on the driver itself. There's also something called manual and automatic pressure control, so I'll go into that shortly. And then another difference is the piston technology that they use for the driving and suction pressures. And there are only 2 piston systems with the driver. So again, with a BiVAD, first piston will run your LVAD, the second piston will run your RVAD, and if one of those pistons fails, the other piston will have to pick up the work of both VADs, and it's going to alternate between the 2 every 2 pump cycles, but that's an emergency like driver change out in that situation. So we'll talk about the battery first. If you can look on the bottom right, you'll always have 2 batteries inserted into the driver itself. And then each patient also gets 2 additional batteries with a charging unit. And in the driver, there is an emergency backup, again, a minimum of 30 minutes with that. And as long as you have the driver plugged into wall power, you are going to be charging the batteries that are inserted in it and the emergency battery. And when I say there's a minimum of 5 to 6 hours or there's a minimum of 30 minutes on these batteries, really it depends on your pump size and rate that you're using, the pressures that you're using. So the battery time can be longer than that, but a minimum of 5 to 6 hours or 30 minutes with the emergency battery. And I mentioned now we can measure flow with these. It's measured via ultrasound, and you can add the flow probe to either the inflow or the outflow cannula. And with the flow sensor, we can set an alarm threshold, which is nice. It will alert you to a low flow. So it's great to get like quick detection of potentially inadequate support. Along the bottom, you can see there's different sizes of the flow probes, just depending on what cannula size you're using for that patient. And the blue plastic comes off, you place the tubing in there, and then the blue plastic goes back over the top. And then we also get a cable wrap with the flow probe, so that ties in your flow sensor cable with your drive line and keeps that nice and organized to where they connect on the top of the driver. The flow sensors have a precision, I believe, of plus or minus 15%. And then the flow that is measured and displayed is the average over 5 pump cycles. The panel PC is our new change from the integrated laptop. So this is, like I mentioned, a touch screen where you review and optimize your settings. You do still have to log in like you did with ICUS, but there are 3 different modes you can log in as. So you can be local, which is just basically a display only of your like pump flows, your pump pressure curves. If you log in as medical, you do have access to change pump parameters, except for the manual versus automatic pressure control. And then logging in as expert, you have access to all of the functions. You also can silence alarms for 30 minutes when you're logged in as expert. That's what we as perfusionists typically log in as when we're doing initiations, explants, pump replacements, things like that. Across the top is where you're going to select kind of what view you want to see with the panel PC. So you can go between flow, the pump parameters, which are going to be your systole, diastole settings, your pressure curves. The pump configuration is going to be a review of how you set it up as LVAD, BiVAD, et cetera, what the pump size is, the cannulas you're using, and the patient size. There is an alarm history tab as well, so you can go back and see what alarms you've had on that patient. And then if you have an active alarm, if you can see the yellow bell, that's going to pop up if you have an active alarm. There's a docking station that comes with the panel PC, so really acts as a stand for that panel PC and then also charges it. And then the active driver does have a cable, a USB cable to connect to the panel PC, and you have to have that connection made to log in as medical or expert and to make changes to your pump parameters. The alarms are a little bit different with the active driver. You do still have your audible and visual alarms, but now you're going to have a different color depending on the priority of the alarm and a different tone as well depending on the priority of the alarm. So as you can see, red is highest priority, yellow is middle, and then white is kind of lowest priority. The alarms are also now coded depending on what the alarm is. So H would be hemodynamics as far as like pressure or flows. P is power, which is like a battery alarm. S is system, is going to be specifically for the driver if there's any kind of defects with the driver. And then T is a temperature alarm, which is going to be either a high or a low temperature for the driver itself, the batteries, or the flow sensor. The driving unit will automatically cancel the alarm if the issue resolves on its own, so you no longer have to acknowledge if there was an alarm. As I already mentioned, you can silence the alarm when you're logged in as expert for 30 minutes, but any new alarm that occurs is going to give you an audible and visual alert. And then the audible will get increasingly louder until you resolve or acknowledge that you have heard that alarm. And now finally, we'll get into the pressure control. So manual pressure control is what we've always been used to on the ICUS. You manually set your systole, diastole pressures, and we're going to use that still during implant, explant, pump replacements, or anytime the chest is open, anytime you want to have manual control of those pressures. And the new feature of the active driver is the automatic pressure control. So this is going to be intended for continuous patient use once they're stable in the ICU and once the chest is closed. And with this, the driving unit itself is going to kind of optimize the driving and suction pressures and be able to use the least amount of pressure needed to get that full fill and empty of the pump. The difference with this is if you do need to make any changes to your systole and diastole, as you can see on the picture, it's going to be a plus or a minus change that you're making. You're not going to put in a direct number. You can do plus, plus, or minus, minus. Those are going to be bigger changes in your pressure. And then plus and minus are going to be smaller fine-tuned changes. These are not specific values. It really depends on each patient specifically. So just to recap, With the ICUS and the active driver, there are no changes in the pump parameters that we're used to seeing. Those are all completely the same. All of the disposables are the same, and the hand pump is the same. And so now I'll go through kind of what we like about the new active driver. Obviously, the size and the weight is a lot better for us. It's a lot more compact. For our center specifically, we usually just pick it up and place it in the patient's ICU bed if we need to do any transports. The long battery life is also really lovely. And the stroller, as you can see pictured here, is really great for the family, so they can get the patients out of their ICU rooms and kind of walk around the unit and, you know, say hi to all of their favorite nurses. So it's really nice for our patients. It is also quieter than the ICUS, which is really great. And especially when you go from manual pressure control to automatic pressure control, it gets even quieter. The silence alarm button for 30 minutes is really nice as well. Typically, I've had like temperature alarms that go off. Let's say we're in the cath lab and the patient's draped and covered, and you get a high temperature alarm for that flow sensor. So you can just silence it, because obviously I can't undrape the patient at this moment and, you know, fix that alarm. We also do like the flow probe. Previously, we would kind of do slow-mo and look at how much the pump is filling and say, well, okay, maybe it's 90%. Based on this pump size, this rate, that's probably this flow. But now you have a flow sensor that's going to tell you, you know, what flow you're giving to the patient. And it's also nice to have that alert right away when inadequate support is detected. And then lastly, I'll go into what we dislike about the active driver so far that we've noticed. On the panel PC, you're still stepping to de-air, but it is a very slow process. You have to press the button, it kind of grays out, and you have to wait a second or two, and then it'll allow you to press it again. So it's even slower, I would say, than the ICUS was to de-air. You could also hand pump if you wanted to, but having it already connected to the driver and just being able to step and then start it on the panel PC is easier if it was a little bit faster. There's also a caddy that the active driver typically sits on in the patient's rooms, but it is not very easy to transport with. I would say it's maybe slightly better than the ICUS is, but it's nice that we can just pick it up off the caddy and place it into the patient's bed. There's also an alarm that we've encountered with this that's called the S4 alarm, so S for system, and it basically says that the driver is defective, and we've seen it happen with the power cord disconnection. So when the driver is connected to main power, the cord goes from the driver to kind of that big like power block, and then another cord from there to the wall. And so if it becomes disconnected at that big power block, you can get an S4 alarm. Or we've seen it where the cord is unplugged from the wall, but then maybe you're just untangling something, plugging it back in right away, and it'll alarm at you for that as well. So they've told us you have to wait 10 seconds if you unplug before you plug it back in. But that S4 alarm cannot be cleared. You have to exchange the driver out and send it back to Berlin. So it's kind of a pain when you run into that alarm. The automatic mode with that plus and minus is kind of difficult to get used to, I guess, for me especially. I like that control of knowing a specific number that I'm changing the pressures to. But it's, like I said, it's different with every patient, with every pump size. So it's a nice feature, but also it's something to get used to, that you aren't changing the number specifically to what you want. And then I have flow probes listed on here as well. That is not a typo. It's kind of a love-hate relationship with these flow probes. The placement in that picture is what Berlin recommends. It's right at that connection between the cannulas and the pump inlet and outlet. Which is great until you have temperature alarms, because the flow probe is sitting right up against the patient's skin and you need to kind of rotate it and readjust. With the tie bands right there, it can be a little bit difficult to kind of place it properly. Also, the blue plastic that I mentioned that you have to put over the top of the tubing is difficult to remove, and it's plastic, so it can easily break. They are, like I mentioned, very sensitive to temperature. they can get very dirty and dusty, and you have to watch where they're placed. If, they're near a patient's diaper, make sure those stay clean. And then the cable wrap, in theory, again, is very nice to have the organization of the cable with the driving line to the active driver. But again, it's not very easy to wrap all the cords together. And if you kind of have a mistake going, you have to start over from the very beginning. So like I said, it's kind of a love-hate relationship with the flow probes. And this is just some references, and I will finish with that.
So thank you so much, Samantha. Obviously we are very behind. The awards are in the other room. This is for the FPP and Pillar Awards, all of that. So please go to that to support everybody. And if you have questions for the speakers, go find them in the hallway. Thanks, everyone.